Welcome to another edition of Medicine Makers, where if your destination is a career in medicine, we are going to show you how to get there. I am your host, Dr. Lamenta Sweetie Conway.
And I'm your co-host, Ishmael Mendoza, and you are watching us on CAN TV Live on Channel 21 or 99. You can also find us online on cantv.org/hotline.
Definitely make sure that you do that. Follow us and plug us in. We are super excited on today to have our guest with us, Dr. Felicia Davis Fourte. And I'm going to have her tell us a little bit about herself in just a few moments. But just believe me when I tell you, she's one of our Am Abel Foundation physician mentors, but she's had decades of leadership and medical education here in the Chicagoland area, and definitely one of the female women of color in anesthesiology. We're proud to have her as part of our group, and proud to know her as a woman of color that is a physician serving here in Chicago, doing just so much impactful work. She started in anesthesiology. She's done pediatric anesthesiology, even boarded and trained in critical care, and now she's doing addiction medicine. I mean, her list and the talents just go on and on. So we welcome you, Dr. Felicia Davis Fourte. We're so happy to have you.
I'm so happy to be here. Thank you.
Thank you so much. And we'll be talking a little bit more and sharing about the work, and we're going to be talking today about the opioid crisis. But before we get into that, I just want to remind you guys that we have some wonderful things that are coming up for Am Abel Foundation. And one of those is our 3-on-3 basketball tournament. Right, Ishmael? Mm-hmm. So we are trying to get our young men of color, you have to see it to be it. So we are trying to encourage our young boys that there's something other to do other than to ball. You can be a baller, but there's different kinds of ballers. So this is a 5th through 8th grade tournament for our... Sorry about that. This is our 5th through 8th grade tournament that's going to be at Loyola Stritch. So it's going to be at the Loyola Center for Fitness over in Maywood. And it's our Top Docs and Hot Shots 3-on-3 basketball tournament for 5th through 8th grade boys. If you have a young kid, it's open to all children, but we're definitely looking for our young boys of color, African American, Latino kids who wouldn't otherwise have this amazing opportunity to be around Black men in white coats, brown men in white coats, young boys of African American men and Latino men who are in medical school, who are willing to share a game of basketball and talk and introduce them to medicine as well. It's going to be a fun day. Our young boys will have the opportunity to visit the anatomy lab. They'll learn things like CPR, stroke management, what to do in case of a heart attack. They'll get a chance to interact with real live cadavers, and their experience is amazing. If your young son or if you have a nephew or a kid in the family that's interested in this amazing outreach program, please have them visit www.iamabel, again, www.iamabel.org. And you can register on our homepage for this really wonderful event. So before we get started, just want to let you know that this is a live call-in show, and we are going to be talking about the opiate crisis that has hit America. As I tagged it on Facebook, America Addicted. And our co-hosts, Ishmael Mendoza and Dr. Felicia Fourte, is going to be talking to us about the opiate crisis. If you have questions, please don't hesitate to give us a call at 312-738-1060. Again, 312-738-1060 is our call-in number.
And before we begin, I would also like to encourage viewers to share our live streaming link on social media platforms such as Facebook, Twitter, and Instagram. So to top off today's discussion, I think we would like to show a video that really describes and hits home a lot of the topics we'll be discussing today, as well as explains the relevancy of today's issue of the opioid crisis.
What is the opioid crisis? Opioids are a class of drug that include both illegal and prescription drugs, such as oxycodone, morphine, hydrocodone, and many others. They can relieve pain, but also create a high risk for addiction and overdose. In 2016, 741 people died of opioid overdoses in Chicago. In the state of Illinois, 1,889 died. However, the death rate in Chicago is almost double that of Illinois, at 26.7 deaths per 100,000 and rising. Increasing overdose deaths can be attributed to the recent influx of fentanyl. Fentanyl is cheap, indistinguishable from heroin, and between 50 to 100 times stronger than heroin. Just 2 milligrams of fentanyl is enough for a lethal dose. The opioid crisis affects everyone and isn't limited to any demographic, place, or person. Surgeon General Jerome Adams issued an advisory stating the importance of the overdose-reversing drug naloxone. Naloxone, also known as Narcan, is a medication that reverses the effects of an opioid overdose. If you recognize an overdose, naloxone can save a life. You can visit one of many Chicago Recovery Alliance sites across the city, where training and free naloxone kits are provided. You can also find naloxone at your local pharmacy. To learn more about the opioid crisis, visit overcomeopioids.org.
So that is a little introduction to the subject, and we like to talk to our doctor. But first, I just want you to tell us just a little bit about this amazing journey of yours to medicine and how it led you from where you started to where you are today. And then we're going to ask you some hot topics that we have on opiates.
Okay. Well, I'd have to say I actually started this journey at the age of 4.
Wow.
When I knew I wanted to be a physician. And growing up in Shreveport, Louisiana, which is where I'm from, I just continued the pursuit. And fortunately, when I told my parents and I told the physicians when I was a little girl, they just helped me and encouraged me. And so I just kept that pursuit. I went to Howard Medical School. I graduated from Howard University in Washington, D.C., and I came to Chicago in 1984, where I was pursuing internal medicine, wanting to be an ophthalmologist, and found out ophthalmology wasn't for me. I went from there to becoming to looking and discovering the world of anesthesia, and found that it was the kind of life that I wanted. It was exciting, it was challenging, every day was something different, and I just loved it.
Wow.
Yeah.
And then from anesthesia to what you're doing today, because for our listening audience, like I said earlier, she is definitely one of our heroes in medicine for sure, and definitely an example for young people to follow who really want to know what it's like to pioneer in a place that has not been well traveled before. Yeah. And I mean, that is definitely an example for our young women, especially to follow. But now that you are not really practicing in that world of that fast-paced world of anesthesia, tell us where you've gone since then.
Well, once I retired, I just retired from county. I like to say I retired from Cook County, but there's no way I could retire from medicine.
Sure.
You know, it's in your blood, and you have to use and give constantly, always. You have to keep giving, and you have to give back. That's just who you have to be.
Absolutely.
With this training and the experiences that I had and have, I wanted to keep giving. And so during my last maybe 6 years doing anesthesia, I started working with people who had addiction issues, but they were living in nursing homes. I wasn't doing, medication management, but I was doing groups. And for these groups, the doctor had to be there probably about 15 minutes, 20 at the most, and I would be there an hour and a half, 2 hours, because I found that people really needed to hear what it was that I wanted to offer them, and they just wanted to learn and know more. So once I finished, with the career in anesthesia, not that I finished, but just the retirement, I had an opportunity to work with one of my husband's friends who was doing addiction medicine. And she told me about it. I said, oh, this would be a great segue. I'm an anesthesiologist.
Yeah.
I know the drugs. I know the medication, and so I just started learning more and more and more. I was interviewed by the owner of the location, and she hired me.
Wow.
And then that just propelled me into other opportunities doing addiction medicine. And so I've loved it. I've loved the field. I just always try to love whatever it is I'm doing.
Amen.
Whatever that is. So, and that's kind of how it evolved. And so addiction medicine, actually I'm going to be taking boards in addiction medicine because I would just like to be triple, double boarded, in another field of medicine and be able to give even more. So,
Because there's so much need.
yeah, there is a lot of need.
Your
Yes.
journey is absolutely remarkable, and your passion, remarkable as well.
Well, thank you, Ismael.
I think to start off a discussion, I think it's necessary for the viewers to understand the difference between opiates and opioids and common names that they'll often see in medicine.
Okay, so there's a general category, and that's called narcotics. So all of these medications, they actually fall under the word narcotics. And I want the viewers to know that heroin used to be prescribed. They stopped prescribing it because they found that it was so addictive. So now let's just break down the way the medications are. There are some that are naturally occurring, which is from the poppy seed, and those would be things like morphine and the opiate. But then there are others that are synthetic, and those are man-made and semi-synthetic. And so those are the ones that, when you saw the video, it went over a few of them. But some of the common names, and I'd like to tell you the order in which from the least potent to the most potent, okay? So I wrote it down because I want to make sure you got it. Okay, so codeine is the least potent. And then there's oxycodone, hydrocodone, morphine, hydromorphine, fentanyl, and carfentanil. So now, what those are the groups that we know, and people will use things like heroin because heroin works on the opiate receptor. And so that opiate receptor is stimulated, and once that opiate receptor is stimulated, people are hungry for something that's going to satisfy the opiate need. And so what we're saying, it's like, I like to tell my patients that when you're hungry, do you need to eat? And if you need to eat, do you eat an apple or do you eat a steak? Both of them might fill you up, but the apple probably won't fill you up the same way. And so in this scenario that we're talking about, people need this medication and these illegal and legal drugs in order to satisfy that hunger.
Right.
So those are some of the things. But medication like fentanyl, which is what we use in the operating room, most of these we use, for pain. They're prescription medications. But some, since you saw on the video about fentanyl is a prescription medication. We use it all the time in the operating room. But one of the things about it, we use such micro amounts. We use it in micrograms, not milligrams.
Right.
And what's happening is that in this overdose situation that's happening is that fentanyl is added to the heroin.
Absolutely. So can you talk to us a little bit about, it's been very well documented that there's been a role in healthcare in contributing to the opiate crises. I actually had my own experience, which I probably don't have enough time to share, when I was actually in Indiana, working at Indiana University or working at Wishart County. And my own personal stance on how I would prescribe opiates because of the way that I personally saw it affecting the population, which actually led to a movement, which would be for another day. But talk about the healthcare's impact or prescribing practices that may have contributed to this.
Well, I think if most people saw a 60-minute special, and if you haven't, go and seek this out, because I think it gives you an overview of what happened. But just to kind of paraphrase it for you, around the 1990s, in the 1990s, it might have been closer to 1999. So now we're in 2019, but see how rapidly this changed. So in around the 1999, the pharmacy companies tried to and told people that, and the healthcare professionals, that opiates weren't addictive, that the way we prescribed them, we didn't have to worry, that we could, give people medication for pain, because the biggest thing during that period of time was, that sixth vital sign, which was pain.
Yes.
We have all the vital signs, and then now here's the sixth. And so people were actually criticized, and we're talking healthcare professionals,
Right.
if they weren't treating people's pains.
Correct.
And so pain became a major issue in the control of pain. And so the healthcare professionals, not really knowing and kind of listening in a way to what was being said, the healthcare professionals started using the medication and didn't really understand, I think, that the amount and the impact and how long, you can have somebody on these opiates.
Yeah.
If it's a short-term therapy, that's one thing. If people have addictive personalities, that's one thing. And so because there's such a short time when you're seeing patients, sometimes you're not able to necessarily determine, is this somebody who's going to be addicted to this opiate? Should I only give this medication for, 5 days when the pain is more intense? Or should I give this medication for 2 weeks? And so, not having the literature that was behind pain management, even though we were doing pain management, as an anesthesiologist, we've been doing pain management forever, and giving people narcotics is not necessarily one of the things that we do. We do multimodal pain management, meaning we use different forms of pain management to
control.
combat pain. So that's kind of what happened, and that's kind of where the evolution happened with medication. So now what's happened is that, I don't know if you want us to
No, go
keep
ahead.
going.
Sure,
So
go
now
ahead.
what's happening, because, this, as statistics show, the number of deaths for opiates have, increased like this. It's not even like this, it's like this.
It's like
And so,
I think it's every 12 minutes,
Yeah.
someone is dying from an opioid overdose.
Yeah. So, I just got statistics here that in 2015, for example, there were 3 million people battling addiction, and that was pain pills and illicits, right? And of that 3 million, 60% deaths were due to opioids.
Wow.
So that's pretty major. And back in 2015, which was only a few years ago, 91 deaths happened per day, not per year, per day. So now it's something like 170 per day people die from opiate overdose.
How do you think the opioid crisis is impacting Chicago specifically?
Yeah.
Because we have a different demographic than what we oftentimes see represented, and in fact, that's been a point of contention amongst people in color, because when there was a crack epidemic, and we've talked about this a lot in our own circles, there wasn't a lot of sympathy or empathy for people of color that were dying of crack, and now there is a lot of empathy and this clarion call that we got to get on this right away. So our demographic is different in Chicago. We have a lot of people of color, minority blacks, Latinos. So the tables are tossed a little bit. How is the opioid crisis affecting or impacting our community? And if I would piggyback on that, and you were getting to that answer, I think, tell us also how the prescribing practices are now turning the other direction.
Well, I'd say that, when I said that I initially started working with medication management, we were using Suboxone, Vivitrol, and also methadone, and that was in the suburbs.
Yeah.
And I will tell you guys that I was shocked when I first started working, because I actually thought I was going to a clinic where the majority of the patients were brown and black. And I didn't see hardly any people that looked like me at all within God knows how many months of working there. And so in that center, the other thing that I noticed was that most of the patients there were intravenous drug users. So that was very interesting to me. Then in 2016, because I started working there in 2015 after I retired in May. In 2016, I started working at another facility, which was on the south side of Chicago. 98% of the patient population were African American. And of that group of patients, nobody was an intravenous drug user. The few people that came in that did not look like the majority of the patients. So that was really a shock to me. So now, getting to how we are prescribing now, people are so fearful because not only are you looking, I was just reading an article recently, and this article really was talking about like how doctors don't even want to prescribe pain meds, narcotics, opiate, at all.
That's true.
For patients post-op. And these are, people with serious, surgical procedures.
Sure.
So that it's a pretty daunting situation. Appropriate pain management should be given, and that means you have to limit it. And now, there are other things that there's things called intravenous Tylenol. Yes, it does work.
It works great.
When you're in the hospital because it's done intravenously, so it crosses the blood-brain barrier, and with that cross, then you're getting the central effects of Tylenol. When you take PO medication of Tylenol, for an intense pain, you're probably not going to get that much relief. Okay, so prescribers have to be, they have to do a lot of searching for themselves to also make sure that they're given appropriate pain management, because pain is a serious thing, and we do want to treat people for pain.
I actually had a patient who was an IV drug abuser who actually lost all of her access and had begun to just pop it under her skin and then develop necrosis and so forth. And actually, in order to change her dressings, we used IV because we didn't want to give her more opiates, and it was outstanding.
Yes.
IV Tylenol.
Yes.
So there are other options. You have any questions?
I believe it's. Would you like to go over possible rehabilitation for those who are already addicted or reliant on opioids?
Yes. Okay, so for people who are addicted, a lot of people will think that you can just put somebody into a treatment center and then they come out and they're fine. Well, no. Remember what I told you about the opiate receptors? These receptors are still hungry, and when you put them in the center, and you might be able to, decrease their use while they're in the center, but when they come out, they need to be in a treatment. They need to be in ongoing medication management. And that medication management, methadone, it works. It's a great, legal medication, and it's prescribed by a physician, so the patient is monitored. What I do is I monitor the patients really closely, especially when they're starting on methadone, and then we have where they come back every 90 days. It's called continuous stay, so that we are also assessing how the patient's doing. So there's Suboxone, which is one of the therapies. The two major therapies are Suboxone, that family of medication management, which is there's a little slip, like a little, those little mouth.
Sublinguals?
Yeah, you can use it sublingually, or you can just put it on the tongue. And then the other medication is methadone.
Well, in the little bit of time that we have left, I definitely want to talk about recognizing an opiate emergency, meaning an opiate overdose. Can you talk a little bit about that? And while you do, we're going to throw up a little visual here as well.
Okay, so For an opiate, if a patient is having an opiate overdose, these patients will usually, these people, they're not our patients, right? This person will be having shallow breathing. They'll be having very difficult breathing. They also will have a discoloration in their skin. If they're of lighter complexion, then they'll be turning blue. If they're of darker complexion, you have to look at the nail beds and you have to look at the lips. The other thing that you'll be seeing in this patient population is that they won't be responding to you. And it's hard. You try to nudge them in the chest and they won't be responding. And so you have to call immediately 911. And then if you have Narcan or naloxone, you have to use that. And you can give that between 3 and 5 minutes, but repetitively. Some patients require 2 doses. Other patients might require 1. But because of the 911, they should be on their way to help you save that person's life.
Absolutely. So just remember, in an emergency, definitely call for help, call 911, activate EMS. But also, for those of you who are watching, if you have family members who you know who are addicted to opioids or who are addicted to heroin, please ask them to ask their doctor or go with them on a visit and get Narcan so that you can be a person that might save their life. The life that you save may be that of your family member. We want to thank Dr. Felicia Davis Fourte for coming with us. She's been a blessing. And we'll hopefully have her come back and talk a little bit more about opioids, and we hope you learned something. Thank you for joining us.
Thank you for having me.
Thank you.